Excuse me, don't know. Don't know. This is our
The shake code is because we used to buy oil from them. And they're proud to be Australian as well. So, are you alright?
So when did you arrive to India?
We arrived on 38.
So this is the second stop in India. So from here we will be heading to Delhi.
Tomorrow to Delhi. And then go up to Rishikesh. So tomorrow we have a meeting with the minister.
Broad perspective of this entire.
That's the best question actually. The broad perspective is Dr. Delegation, Dr. Henry, the Australian stroke alliance. As you know, stroke has become a very big challenge in India. Every day. So right now, pre-hospitalization hospital, and they have really gone very deep into this aspect and created best of the protocols, best of the research-based clinical practices, including city enabling means all in-house care that leads to better, if the patient is strong, care immediately as soon as the ambulance arrives or the paramedic arrives, not training the doctors, training the institution. Everything is part of ASA. So that you can have better future when it comes
undergraduate college plus we have started from last already completed 2016 our college is and the second batch is in the internship now and the first batch of postgraduates are already in the course and this year the second batch of postgraduates are
Good afternoon, ladies and gentlemen, to this magnificently glorious day. It gives me immense pleasure to extend a warm welcome to the dignitaries, faculty members, and the students on behalf of Kanachur Group of Institutions. I, Pradiksha Shetty, Assistant Professor, Kanachur Institute of Allied Health Sciences, on this pleasant and joyful morning, feel privileged to host this interaction meet with Met Parliament delegates. Met Achievers is a recognized leader in the India-Australia relationship. The company, consisting of high-profile accomplished CEOs and promoters of various organizations, is an industry pioneer in healthcare, operating in areas including digital health, diagnostics, genomics, healthcare, M&A. Embedded as a stalwart in the healthcare industry, the agenda of Met Parliament is to create a strong ecosystem with the leaders involving young healthcare professionals towards holistic development of healthcare. The intention of this session is to discuss the opportunity for collaboration in education, discuss strategies, case studies, and emerging approaches to the transformation of pre-hospital care, identify future-facing practical skills such as familiarization with digital health, connected devices, international treatment standards, and more, which students require, and define problems and solutions to help increase cross-border opportunities and mutual recognition readiness. Kanachur Islamic Education Trust, under the guidance of Haji Uke Sir, was established in the year 2000 with the following branches: Kanachur Primary School, Kanachur Public School, CBSE affiliated, Kanachur Pre-University College for Women, and Kanachur Institute of Management Sciences. Since Haji Ukimono Sir desired to serve the general public, he envisioned to start Kanachur Hospital and Research Center in the year 2014 to serve the poor and needy people. Kanachur Hospital and Research Center is a charitable hospital having a state of infrastructure and technology, providing tertiary level health care with world-class care facilities supported by a team of efficient, highly qualified, skilled consultants and paramedical personnel. Kanachur Hospital, built to have 1,000 beds, 10 operation theatres, 60 ICU beds which provide 24/7 services, departments like emergency, critical care unit, blood bank, pharmacy, central diagnostic lab, radiology and ambulance services works round the clock to attend promptly according to the requirements of patient situation. Kanachur Institute of Medical Sciences, Kanachur College of Physiotherapy, Kanachur College of Allied Health Sciences and Nursing Sciences were established in the year 2016. The courses are well defined with clear learning outcomes and suited to develop the knowledge, skills, and attitude of the students. In addition, students are also given adequate guidance and exposure in research methods and encouraged to do research projects. Apart from educational facilities, the institution also provides excellent opportunities for the students to bring out their talents in extracurricular activities. Student intake of MBBS for UG is 150 and for PG is 27. Student intake of physiotherapy for UG is 60 and PG is 21. Student intake of nursing sciences for UG is 100 and student intake for allied health sciences for UG courses is medical laboratory technology 40, optometry 20, anesthesia and operation theatre technology 20, medical imaging technology 20 and renal dialysis technology 10 seats. Today we have with us a list of eminent guests. Dr. Harshavardhan, Group Managing Director, Medtech Group of Companies, Mr. Michael Kos, Director, Digitology Health Tech, Professor Mark Parsons, Titan Director and Chairman, Australian Stroke Alliance Clinical Council, Professor of Medicine and Neurology at UNSW, Southwestern Sydney, Clinical School and Senior Staff Specialist in Neurology, Liverpool Hospital. Dr. Damien Eston, Titan Board Director and Chief of Research Strategy, Australian Stroke Alliance, Director of Strategy at Melbourne Brain Centre at the Royal Melbourne Hospital. Professor Andrew Bibbard, Titan Director and Chief Technology Officer, Australian Stroke Alliance, Associate Professor of Neuroimaging at the University of Melbourne and Head of Neuroimaging Unity at Melbourne Brain Centre, Royal Melbourne Hospital. Dr. Henry T. Espura, Australian Stroke Alliance, Board Director and CEO. Dr. Matthew Atkins, Director, Digitology Health Tech. Dr. Bruce Ingram OAM, Chairman and Medical Director, QSTAT Australia. Mr. Marcus Best, Partner, Minter Ellison. Dr. George Munchnicki, Executive Director, Genetic Technology Limited. Dr. Basit Dahal Mohan, Divisional Leader, Genetic Technology Limited. Dr. Padma Gadir, Founder and CEO, Smilo Australia. Dr. Pramod Basavaraj, CTO, Smilo Air. Mr. Nicholas Howard, Founder and CEO, Hark Medical. Dr. U.T. Iftikhar Ali, President, Indian Association of Physiotherapy, Karnataka State President, Sports and Fitness Training Federation of India, former syndicate member, Rajiv Gandhi University of Health Sciences. Haji U.K. Monusar, Chairman, Kanachur Institute of Medical Sciences. Mr. Abdul Rahman, Director, Kanachur Institute of Medical Sciences. Dr. Colonel K.G. Kiran, Dean, Kanachur Institute of Medical Sciences. Dr. Harish Sethi, Medical Superintendent, Kanachur Hospital and Research Center. Dr. Rohan Monas, Chief Medical Administrative Officer. Principals of institutions, College of Nursing, Physiotherapy and Allied Health Sciences. Last but not the least, heads of the department, staffs and students. It is a mark of our undying tradition to invoke the Almighty at the beginning of an important event. Like the great philosopher Soren Kierkegaard once said, the function of prayer is not to influence God, but rather to change the nature of the one who prays. I would like to call upon Mohammed Sabit and Fatimat Mehek to invoke God's blessings.
Assalamu alaikum wa rahmatullahi wa barakatuh. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. طه ما أنزلنا عليك القرآن لتشقى إلا تذكرة لمن يخشى تنزيلا ممن خلق الأرض والسماوات العلى الرحمن على العرش استوى له ما في السماوات وما في الأرض وما بينهما وما تحت الثرى وإن تجهر بالقول فإنه يعلم السر وأخفى الله لا إله إلا هو له الأسماء الحسنى صدق الله العلي العظيم. السلام عليكم.
I seek refuge in Allah from the cursed Satan. In the name of Allah, the most merciful and especially merciful. We have not sent down the Quran onto you to cause you distress, but only as a reminder to those who fear. A revelation from Him who has created the earth and the high heavens. The most gracious rose over the mighty throne. To Him belongs all that is in the heavens and all that is on the earth, and all that is in between them and all that under the soil. And if you speak the invocation aloud, then verily He knows the secret and that which is yet more hidden. Allah, none has the right to be worshipped but He. To Him belongs the best names.
Thank you, students. We all feel blessed indeed. Now we will be presenting a short video which provides a glimpse of various facilities available at Kanachur Hospital and Research Center and its attached group of institutions. When you welcome love with your whole heart, soul, and body, love will welcome you with all its sweetness. Now, I request Mr. Abdul Rahman Sir, Director, Kanachur Institute of Medical Sciences, to formally welcome the gathering.
Namaste and very warm good afternoon to all the delegates of Med Parliament. Welcome to coastal Karnataka. Mangalore is a leading educational hub in the state of Karnataka because we have very many promising resources at bay, and the people from this region are intellectuals in various forms and professions. I would explicitly like to talk about this wonderful city of Mangalore. It's beautiful. The Ghats, especially, comprise natural mountain terrains and wide variety of flora and fauna. Weather is warm and humid, and we do have rains too here. Our heritage goes back for hundreds of years. A rich environment for students, for education, and the culture here as a unique blend of time and religion. We do have blue flag beaches marked here. Our food culture and seasonal cuisines are so unique that people visit us throughout the year. What we enjoy the most here is the amalgamation of religions and the cultures in this beautiful belt. Our city is well connected by rail, road, sea, and air. We do have the international cruises which is coming in from the various parts of the world to Mangalore port, and also the international flights. We are well connected. Especially right now, we are connected to the Gulf. Most of the Indian carriers, they fly to Gulf, and so we are well connected there. Of course, Kanachur institution ventured into education. You might be asking why. My father, who's the chairman of the institution, he had a dream. Although he wanted primarily, we are 4 siblings. My father, he's got 4 children. I'm the second, and I have got 3 sisters. So we are, by the grace of God, we are well educated. One of my sister is a doctor, and she's a radiologist, and my brother-in-law is also a surgeon, and they too have a medical college in Kerala. So fortunately, we are the 4 siblings. We are well educated, but then my father, he was not having that. He was not fortunate enough to get that education, and but still, by the grace of God and his hard work, he has built a strong empire, business empire in India and abroad, and also the education institutions. And the aim and this dream was because this village, the Derlakate, which the institution is located, this is where my father, the chairman, was born. And his dream was back in 20 years back, we never had good schools. So primary education, his motto was to have every individual from this village to be educated and go to the next level, whatever he or she desires. And today, by the grace of Almighty, I'm proud to say, we have in our school, the children who are studying today, their parents are our students once upon a time. So that kind of transformation our education institution has got its change. And it is a vision of my father and the chairman of the institution. We wanted to start with this education institutions, and of course, growing forward, the need for healthcare, which is ever growing, and the requirement is increasing day by day, and also the newer diseases and things gets unfolded in this world. And during this COVID time also, past 2 years, the institution was the pioneer institution in Mangalore. We were the first institution among presently in the district of Mangalore. We are having about 9 medical colleges and hospital. But we were the first institution in the medical college. We went forward and we said we are going to accept the COVID patients, and our nursing personnel and our doctors were the first ones who served the Mangalore district government hospitals. So it's a team effort by our doctors, our nurses, and our paramedics, and the team of the administrators who made it possible, worked very closely with the government hospital in Mangalore, and also we could sail through this pandemic, and today we are fortunate and we are alive, and we are seeing the bright future ahead. So outcomes of our students' rich setting for learning and activity have reached amazing heights, and our students who have graduated from our institution, be it MBBS students or nurses or paramedics or the physiotherapist, the physical therapist, they are now working across the globe, and they are working in US, they are working in the UK, they are working even in New Zealand. These are our students have reached far-reaching boundaries, and they are in multiple countries now. So higher education, our vision, the vision of our institution to offer diverse educational programs that facilitate the development of competent professionals and valuable citizens who demonstrate excellence in the respective disciplines while being locally and globally responsive in the areas of medical education, healthcare service, and research to provide a world-class holistic healthcare system with a focus on compassionate patient care to the needy people. The mission of our institution, Kanachur Institute of Medical Sciences, will actively promote and preserve the higher values and ethics in medical education, healthcare, and research, and will pursue excellence in all these areas while continuously meeting the expectations of the people it serves without prejudice and in all fairness, to stay socially meaningful in its propagation of various arts and sciences to serve humanity at large. The planning phase was intense, and we had tight timelines. Medical programs of our institution was initiated in the year 2016. We ventured into medical nursing, physical therapy, optometry, operation theatre technology, medical lab technology, renal dialysis technology, medical imaging technology, etc. And the course keeps growing. Our reasons for going this far: to address the healthcare resources gap in India, to create verticals of excellence, create healthcare training leaders. Our institution is affiliated on a national level with the National Medical Commission, erstwhile Medical Council of India, New Delhi. Our state affiliation is to Rajiv Gandhi University of Health Sciences, the state government university of good standing. We are also affiliated to Educational Commission for Foreign Medical Graduates, USA. Yes, the Indian healthcare ecosystem has a lot of infra and medical equipment requirements and affiliating bodies, and we have successfully completed all our audits successfully. The future plans of the institution is we are coming up with Ayurveda Medical College and a hospital this academic year, and also a pharmacy college in this academic year. Of course, we are in the phases of research center with toxicology labs, which going forward our institutions will also be venturing into and getting into research. So with that, with this, we look forward for a lot of collaborations with the Med Parliament in this space of academics, research, and any other things, whichever you deem fit. In this August gathering, I would like to welcome all of you to the Kanachur Healthcare Institutions. Firstly, I would welcome Dr. Harshvardhan, founder and Group Medical Director, MedAchievers Group of Companies. I request our Honorable Chairman to just present a shawl to sir. I request, he's not here? Okay. So the next person, Professor Andrew Byward, Titan Director and CTO, Australian Stoke Alliance, and Associate Professor. They're not here too? Okay. Dr. Henry D. Ispura, Australian Stroke Alliance Board Director and CEO. Next, we have Dr. Damien Easton, Titan Board Director and Chief of Research Strategy, Australian Stroke Alliance. Next, we have Mr. Michael Koss, Director, Digitology Health Tech. Welcome you. Dr. George Mucin-Niki, if I have, ED Genetic Technologies. Welcome you, sir. Dr. Bruce Ingram, Chairman and Medical Director, QSTAT, Australia. Welcome you, sir. Next, we have Dr. Matthew Atkins, Director, Digitology Technology. We welcome you. Mr. Marcus Best, Partner, Minter Ellison. We welcome you here. Next, we have from our own native place, she's a Mangalorean, proud Kannadiga, Dr. Padma Gadia, founder and CEO Smile AI. Welcome you, ma'am. She's a graduate from Yonopoya Medical College, and she's very familiar to Derlakatte. So she was surprised when we were having a chat. She was saying that she was quite surprised the way the Derlakatte has changed over 20 years. So we welcome you once again, ma'am. Okay, Dr. Dahal Mohan, Divisional Lead Genetic Technologies. Welcome you. Mr. Pramod Basavaraj is here. Okay. Mr. Nicholas Howard is here. Yeah, the founder and CEO Heart Medical. Welcome you. Next, we have Dr. U.T. Iftikhar Ali, the former syndicate member. Welcome you, sir. Please. I welcome all the. I think I have not left anybody. Sir, is done? It's done, right? Yeah. Okay. Yeah. So, in the same, sir, it's done. So, I also welcome the media who are gathered here, departments, and the postgraduate students, the medical MBBS interns, the nursing students, the MBBS students, the allied health science and physiotherapy students. And I wish this session, to be fruitful for all the Med parliamentarians as well as for our institutions. And we look forward for having a fruitful discussion here, and also taking forward various programs what you have in mind, and what plans you have for India. We look forward for that. Thank you once again. Jai Hind.
Thank you, sir, for the warm welcome, and a warm welcome to you too, sir. Chairman and Director, sir, to escort the delegates to the dais. To mark this this event to be a memorable one, let us now witness the inauguration of this day by watering the plant. As the Scottish novelist Robert Lewis said, watching something grow is good for the morale. It helps us believe in life. With this small thought, I request the dignitaries to come forward and inaugurate the program. Henry Ford says, coming together is beginning, keeping together is progress, and working together is success. It was indeed this mantra of working together that has brought us where we are today. Now, I request Dr. Colonel K.G. Kiran, Dean, Kanachur Institute of Medical Sciences, to share the reports of Kanachur Institute of Medical Sciences, College of Physiotherapy, College of Nursing Sciences, and Institute of Allied Health Sciences.
Good afternoon. Honorable Chairman Sri Haji U.K. Monu sir, respected Director Sri Abdul Rahman, Chief Guest of today's function Dr. Harshvardhan, members of Delegation Med Parliament Australia, Medical Superintendent Dr. Harish Shetty, Principals of Sister College, Dr. Suhail, Dr. Mohit Saldana, Dr. Shamima, heads of various departments, teaching and non-teaching staff of the institution, postgraduates, interns, students, Dr. Rohan Mohanis, the Chief Administrative Officer. A very good afternoon to all our present guests who have travelled all the way from Australia to this beautiful city, and we are happy to welcome you all. In our honour, I would have the delegates of the Med Parliament from Australia for free exchange of ideas and knowledge for enduring bonds between institutions and the nation. Being at the helm of the academic affair, I'd like to share with you our journey, our affiliations, our stand at the university, our teaching faculty, our hospital, and why Kanachur then. We started our journey on a noble stand with a 300-bedded hospital with 30 doctors. It grew into a 1,000-bedded tertiary level healthcare facility with more than 250 doctors as on today and 2,500 students on this campus, just in a span of 6 years. Presently, close to 2,000 students are residing in the hostels. We provide undergraduate and postgraduate clinical programs in this clinical facility. Over a short period of time, we added on more professional colleges, affiliations, associations, tie-ups with government, peripheral health centers and district hospitals, and the process goes on. Our clinical facility has done many more rare cases and recorded their findings to share their various academic flora. Our students have earned accolades in academics and also in sports. As far as our affiliations are concerned, we are affiliated to National Medical Council, RGHS, that is Rajiv Gandhi University of Health Sciences, National Accreditation Board for Laboratories, Indian Nursing Council, Physiotherapy Association, Indian Medical Association, Academy of Hospital Administration. About a stand at Rajiv Gandhi Health University, Kanachur institution stands tall because of the academic proficiency. The students of the medical college, physiotherapy, nursing, along with the allied sciences, have collaborated with research, published articles, won accolades, and won grants also. We have had 100% admission since 2016, and that is a great feat to be achieved. This year we have started postgraduate courses in 8 clinical subjects. Our strong interest in research, we plan to establish an animal house with the needed audits and affiliations to conduct lab and toxicology studies. Our teaching faculty have earned accolades in state. They have been featured in allied best teaching category 2. Our clinical and surgical facilities have international fellowships to their experience and credit with the personalized patient's care. Requirements for training are well suited with central library with more than 13,000 books and 400 journals. The nursing, the physiotherapy, the allied health teaching facility are commendable. Their students earned the top ranks too. Our teaching hospital is a 1,000-bedded facility with 10 operating rooms with 60 beds exclusively for critical care, from minimal invasive surgeries to handling trauma. We have it all. The work is efficiently, and they manage the patient flow with ease. That is 24/7. That is 7 days a week, 24 hours a day. They manage. I admit the COVID pandemic was a huge shocker and game changer, much to our reasoning. Though many of us have not planned our hospitals for the pandemic, our doctors and nurses did a commendable job fearlessly. Our students of nursing, physiotherapy, allied sciences were beacons of care too during the COVID with needed guidance from their superiors. Kanachur Hospital was the first hospital in the region to start COVID vaccination. We served the needy and the aged both far and near, and the COVID vaccination team was very proficient in their duties. Kanachur has an enable molecular lab with H1N1 and coronavirus. We have the best turnaround time in the district, which has been highlighted and noted for our capabilities by the district. We are in the process of expanding the range for other viral and bacterial markers too. The central lab boasts a system for biochemistry and pathology that is with a turnaround friendly time with the best possible results. The backbone of the hospitals are the nurses and the MLT technicians, that is medical laboratory technicians, and other allied staff who are the torch bearers of these institutions. The hospital team has conducted more than 150 medical camps throughout the state, covering about nearly 500,000 population, both in the state and also in the nearby state. In the super specialty services, we have initiated medical oncology, surgical oncology, thoracic surgery, urology and andrology, nephrology, endocrinology, neurosurgery, spine surgery, hand and microsurgery. And the costs are very affordable compared to any international health centers. Another unique center is the Kanachur Institute of Craniofacial Anomalies. We boast of having 5 accredited centers, in which one of the centers within our hospital, which does orthognomic work apart from cleft lip and padded cases. A unique stand for a hospital that has less than a decade of existence. So Kanachur could be a preferred destination for educational exchange, skill exchange and collaborations, mentor exchange programs, sharing critical surgical interventions, research, all for greater good and service of Medtech. Thank you. Jai Hind.
Thank you, sir. Now it's my privilege to request Dr. Harshavardhan, Managing Director, Med Achievers Group of Companies, to share his thoughts and ideas with us.
First of all, thank you so much, entire Mangalore, for inviting us to this beautiful city. You know, I came in 2007 here, and after 15 years, I am here again. It looks like I was yesterday here only. The city is extraordinary. You can't compare a coastal city with any city in India. And then I need to thank Kanachur Institute. Very, very important to thank the chairman and the director, and not to forget Dr. Iftikhar, who has been the reason why we are here. He invited us, he said that you come to the city of education. What an important word education is, right? But you know, one education, before getting into why we are here, I understand what Dhirubhai Ambani had, or your chairman had, is the education of life. What he felt while he was not able to get what you are able to get, and who could create what you should get. Probably that journey he could travel here, or Dhirubhai could travel in Mumbai and create a reliance. So we should clap for him for creating this as an opportunity for all of us to be here. See, we all are privileged to study somewhere and learn from someone, but that someone would have learned from someone who was that point in time having no one, right? So education is something which is transferable asset, and when you transfer it, it grows. And when you transfer it across the borders, it becomes mega. And that is what we are doing today. When we are talking about education, we are not limiting ourselves to bookish knowledge, because that is what we all have all the time, and we are bored of it, isn't it? You're not bored of the bookish knowledge? Yes. Then you should be louder. If you're bored, you are bored. There's no problem. Your chairman will close his eyes. Are you bored of bookish knowledge? Yes. Do you want something more practical? Yes. Very good. So we are here to talk about the practical aspects of medical science today. Whether it's education, whether it's technology, whether it's pure medical science, or whether it's allied medical science. We all know that it has been an era of understanding post-COVID that doctors were not the only one who suffered the most. We had our nurses staying 24/7 with COVID positive patients. They were wearing PPE kits in this humid environment when there are 4 air conditioners or 5 air conditioners pumping cold air. We are still sweating. Imagine somebody in a PPE kit for 8 hours, right? You feel bad, you feel thirsty, you want to go to washroom, but you hold it all because you have to take care of COVID. So we decided that why not we prepare for a better future. We create a better opportunity for all of us, where not just education but skilling also takes the central place. When we talk about skilling, we talk about genomics, we talk about stroke management, we talk about technology to take care of better health, but we also don't forget about the oral cavity, that is dental care, for which Dr. Padma is here, isn't it? So we start from the mouth and go up to the entire body, but then we forget the guys and the people who are taking care of healthcare, who is taking care of them. Should we not think about you? So we need to talk about the ways to equip you better, make you more stronger, whether you are doctors or paramedics, nurses or preclinical staff. We need to talk about the ways to make you connect to the world. If we don't expose it to you, you can't become one of us. And then, it would be more like a visitor comes, he speaks, he goes back. And you would just clap, you'll have in your mindset somewhere a hidden problem with us, that what are these people doing for us, isn't it? We are here because our chairman said we all have to gather in an auditorium today. We'll find a couple of beautiful faces, we'll have a ceremony, shawl, scarf, and probably plantation. All these you would have seen hundreds of times. We don't want to be just part of this ceremony. We just don't want to be any other delegation to your campus. We want to be with you and ensure that when we are starting a project, we all involve you all. Is that a good idea? Yes. Very good. I think these guys are very much not agreeing to me. They don't want to be us. You want us to be here? Yes. So please welcome us. We would love you if you love us. So that is very important. So my humble urge is that we have to, in this short span of time, become friends. So Med Parliament, as the name says, we are medical parliament. Parliament for medical professionals, not doctors only. Medical science, complete medical science. And we are a global body across the world. We are present in 6 countries today. And we work closely with whether it's National Health Services or Australian government initiatives like ASA. We don't try to bring just context and create a situation which leads to mirage. We create a situation that leads to a solution. You understand mirage, right? All of you studied physics? Had good marks? Then say yes. Otherwise, I feel like, you had a friend who was good at physics and he just passed paper to you. So, if you all studied that well, we don't need to have a mirage here. We need to have facts and figures. We need to hold our hands together and say that yes, we are here and we have a way to work together. So we have got one of the finest delegation that you can ever imagine. We have Australian Stroke Alliance represented by Dr. Henry and Dr. Easton, Damien Easton. Easton is the last name. I'm so sorry. I'm a bit nervous looking at so many talented faces. Then followed by that, we have Dr. Bruce. Dr. Bruce Ingram is one of the, as you can see, senior most member of our delegation. But more importantly, he's one of the most famous physicians of Melbourne. He was one of the fortunate doctors to treat Queen Elizabeth II. She is no more. So we have to honor, her soul. But as she was alive, he was the one who could treat her when she was visiting Australia. She was visiting Melbourne. And he is also fortunate to be doctor of a lot of royal people of the country. But more importantly, he devised a way to help nurses and paramedics. Think about a doctor practicing every day and thinking about you by developing a syringe which helps you to be away from needle stick injuries. You understand needle stick injuries? Yes. You understand? Yes. They understand, their professors. What is needle stick injury from the back, please? Anyone? Whoever today raises hand, I promise you I'll have a surprise gift for you. Come on. No. I don't want it from the professors. Anyone from you, please. Very nice. But it can be another situation when a GDA is gathering those used syringes, or the disposal guy is coming for the final disposal and he has gloves for everything, but then he didn't realize that by accident, a needle was left in the garbage bin. Which it happens in the hospital. Whatever you do, it happens in the hospital. If we have a syringe that takes the needle back inside its body as soon as we inject the medicine or the drug, wouldn't it be a good idea? The needle would not be there only. So there would not be a chance of accidental thing. So if a doctor is thinking like that, you should be passionate to talk to him and connect with him. I will not be talking about ASA before I play a video for you, because then you would know what Australian Stroke Alliance and Titan Neuro is going to do for you. They are actually to bring, not for doctors, but for paramedics, a situation where you become one of the clinicians actually. In Australia, there is something called nurse clinics, where nurse practitioners, In India, we don't have nurse practitioners. We say, oh, she's a nurse. But we say she is a nurse because she is going to take care of the patient more number of hours than a doctor. She becomes the hand for a doctor and the most reliable friend for a patient for 3, 4, 5, 7, 10 days of his admission in the hospital, right? But when you put a specialty in a nurse, that nurse becomes very important asset to the hospital. And when you go to the organizations, not just in India, abroad, or even to Delhi, Mumbai, you are most sought after, right? So you should listen to them very carefully when they are talking to you. Now I'll talk about a very important topic which everyone today is talking about, genomics and molecular diagnostics, right? RT-PCR kit for COVID testing, buccal swab tests and all. Why? Because that is basis of our survival. That is what we are. We are made up of DNA, isn't it? Oh God, you're not saying yes. Yes. No? Yes. Very nice, thank God. And do you think we have RNA as well? Yes, we have. We do have RNAs. We have RNA and we have DNA both. Viruses have RNA as the genetic material, but we have both. And different types of mRNA. I don't want to take a class on genomics and molecular biology, otherwise you guys will down and we have this snoring noise everywhere. So, moving quickly forward, all these things, we just listen, we just imagine, and we say, okay, this is something which is futuristic. Do you think when the future will come, if we keep saying this is futuristic, in 2020, every futuristic thing became a reality. When we were dying, when we were losing our people, we said, why can't we have a solution of this COVID-19, right? And now the new strains are coming in. What became basis of management of COVID-19 was molecular technology and genomics. We could find out, what can be the sequence of that virus, started designing the closest possible vaccine, and all this could happen because people were working in their labs with a lot of pathologists, with a lot of lab technicians who were taking the DNA out of the patient's body, RNA out of the virus samples, right? Do you extract DNAs and RNAs? Yes. Hey, Baba, तो बोलो ना yes जोर से. Yes. Very good. या तो नहीं करते हो. You are lying to me. You're lying to me? No. Then say yes. You should be proud that you can extract DNA. I'm not going to ask you these steps. Believe me, I'm not going to ask you all those steps that you follow in your labs. So we connect that world to something called biobank. When we create a repository of this information into one place, which is usable by many other institutions, labs, professionals, while they are solving a medical problem. So that is what Dr. George is going to talk about, and Dr. Basis would be talking about, how we are going to do biobank. Now, last but not the least in the instrumentation segment, and then I'll leave it to your dental queen, Dr. Padma Gadiyar, to talk to you that she's an inventor, a dental inventor. So she would talk about her solution, Smilo, how you can smile better with her app. I will talk about Nick, who is actually a phenomena when it comes to medical device development. He thought about you guys, the nurses, who actually have to manage, say, 50 beds, and you are just due on the duty in the middle of the night. And you have to medicate a patient after every certain interval. And if you miss it, actually the patient gets improper treatment. But you are not deliberately doing it. You are just missing it because that point in time somebody had a better, bigger needs. You just ran for the rescue. And so you missed out on a patient who had to be given a drug at, say, 2 p.m. And you just reached out to him at 4 p.m. So a system he has developed which is going to actually put an alarm and a reminder, a drug can be rendered whenever required, wherever required. And if you miss it, it will give you a complete chart that you missed on this patient so that you can look for rectification and better management. So in total, right from clinical, preclinical, paraclinical to advanced, challenges like a stroke management, we have all the experts today with us. So I'll hand over the mic to Dr. Henry first to talk about Australian Stroke Alliance and Titan Neuro, the types of courses we are looking for. It's not actually course. Again, it's an upskilling program for you, and the kind of work we can do together to bring better value in healthcare system and in your life as well. Okay? Yes. Thank you so much for not sleeping during my speech.
Well, thank you, Harsh. And can I begin by thanking all of you for taking time out of your very, very busy schedules to come and spend some time with this group who are really excited about sharing some of the things we're working on in Australia. And I'm here to represent the Australian Stroke Alliance, which is based in the Royal Melbourne Hospital in the Neurology Department, but is a group of well over 30 organisations right across Australia. And our focus is acute pre-hospital stroke care. Acute pre-hospital stroke care. And to do that, we've begun by running a system called a mobile stroke unit. And that is, if you can imagine, an ambulance, a stock standard ambulance that you would have here, but we have put in that ambulance a CT scanner. Why have we done that? 2 reasons. 1, when a patient has a stroke, 2 critical clinical aspects emerge. 1, time is brain. Every minute that is wasted between the stroke and then being taken to a specialist stroke centre is causing brain death. And brain death means either true death or long-term, lifelong deficits and disabilities. Second critical issue is that for a clinician, a neurologist, as you'll all know in this room, to make a clinical decision, they need to be able to differentiate whether the stroke is a block in the artery or a bleed, hemorrhagic. And to do that, you have to take a picture, an image. And the best way to take that picture is with a CT machine. And we have that on the road right now in Melbourne. And it's been working for a couple of years with spectacular success. And my colleague, Dr. Easton, will give you some of those details. We've been fortunate enough to get a lot of funding through the Australian government to take that focus and turn it into a mission. And our mission is to say that a heavy, big CT scanner in an ambulance that looks like a truck is not good enough. We need more ambulances, and we need lightweight, portable and inexpensive CT or other imaging modalities, scanners that can give us the picture we need to make those clinical decisions. That's our mission. And from that mission flows our vision. And our vision is that we need to do that in partnership with technology experts and companies that are going to develop those machines over the next 2 or 3 years that do not exist today. You can't go and ring up Siemens or Philips or GE and order one. We're making them. We're designing them, we're crafting them, we're going to deploy them, not only in road ambulances, but as you'll see when Dr. Easton shows what I think is a really good video, but we'll see what you think. We're going to deploy them in aeroplanes and helicopters. Why? Because it's not good enough that metropolitan stroke patients are treated like that. It's not good enough that they have better life outcomes. Australia is a huge country and strokes happen in the countryside, in very remote and rural parts of Australia. And India is a mirror image of that. The patients that in this region will often come to your clinical centres are coming from a variety of catchments. And getting to the hospital is difficult. The time that it takes to get here is tough. But if we can take the hospital to the patient, then the outcome for that patient can be remarkably, remarkably better. And to do that, we've got to put these new imaging devices into transportation modalities that can get there quickly with specialists, paramedics and nurses that are trained in how to do this by us, and that we can then track and evaluate the effectiveness of those clinical outcomes. So that's our vision, that's our mission, and Dr. Easton is going to show you a little bit more of how that works in practice. So thank you for your attention.
Director Sir to escort the dignitaries off the dais. Now we will be having the interaction meet with Med Parliament delegates. I kindly request Dr. Harshvardhan to come on the dais and take over the program.
First 60 minutes after stroke onset are critical. If we can treat during that first golden hour, the likelihood of recovery is much greater.
However, Australians with stroke living in rural and remote locations, particularly Indigenous Australians, have poor access to acute stroke treatments and, as a result, significantly worse health outcomes.
The clock is ticking. If we don't act differently now, by 2050 there'll be a stroke every 4 minutes in this country and 1 million people living with the impact of stroke in our community. That's a devastating thought.
The first step in closing this gap and allowing really urgent treatment has been the Melbourne Mobile Stroke Unit, which brings the hospital to the patient. It was just a normal day. I was just in the bathroom getting myself ready to go to school, and that's when the stroke hit me. My son found me maybe 15-20 minutes after I may have fallen. The mobile stroke unit arrived, then they had me downstairs really quickly for the CT scan. I probably owe my life to the mobile stroke unit and the quick treatment I received. We will be forever grateful for that quick treatment.
The mobile stroke unit is delivering fantastic results for those with stroke in metropolitan Melbourne. We now need to do much more, much better for those in remote and rural Australia.
To make stroke treatment truly mobile, we are miniaturising CT scans to enable us to treat at the point of care.
This is exciting because it will allow the development of the world's first stroke air ambulance and stroke-capable standard ambulances to reach regional and remote Australians. It's time to look to the skies.
We are part of a large team that have joined forces to make a difference. We are leading the engineering activity of the new stroke air ambulance together with our clinical colleagues.
Part of the challenge is developing new materials that make the brain scanners more lightweight and then miniaturising the components so that we can fit this all into an aircraft.
Each year, the Royal Flying Doctor Service retrieves hundreds of Australians from rural and remote parts of the country. The exciting thing about this project, working with the engineers, scientists and doctors as part of the Stroke Alliance, is that if we can make that diagnostic equipment small enough to be packed on a plane and taken to the patient, we'll be able to make that diagnosis sooner, initiate treatment sooner, and as a result, save the lives of rural and remote Australians.
The day-to-day conditions can be trying. I mean, it can be hot. The nearest hospital would be about 500k away. It would be great to have an air stroke ambulance out here so that we could have similar services to the metro area. It would be just unbelievable. It would be great.
Stroke isn't talked about in the Indigenous community a lot. I think I was around 30 when I had my first stroke, and I worked 3 days prior before I even realised that I had a stroke. When I did see a doctor, I was transferred on to our district hospital. I waited 23 hours before I could get a diagnosis. Better awareness would be really good around the rural and remote communities, and quicker access would benefit them in a huge way.
With the mobile stroke unit providing exceptional care for stroke patients in metropolitan Melbourne, the Royal Flying Doctor Service providing stroke care for those in remote and rural Australia, our air ambulance helicopters will bridge the gap, providing world-class stroke care faster than ever before.
This is a unique opportunity to develop a national standard for stroke care that will reach all Australians and transform care as we know it in Australia.
We are proud to be leading this mission, and that's why we're asking all Australians to join us in this once-in-a-generation initiative.
To transform stroke treatment.
To deliver the best care. To build a better future.
For all Australians.
We're with you.
We're with you. We're with you.
We're with you.
Thanks everyone. So you can see exactly what our mission is in Australia. We've been tasked with a really transformative mission for the next 5 years. The Commonwealth has said to us, what a great model that you've established in metropolitan Melbourne with the mobile stroke unit. It's the first and only one in the country. We do have another one that's being launched in another part of Melbourne next year, and there is one being launched in Sydney. But the model, as Dr. Henry described earlier, is one that really is only fit for purpose in a metropolitan setting where we've got the population density to justify the use of a very specialised workforce and specialised ambulance vehicle being created to make sure that we can respond to pre-hospital stroke needs. So out there in the regions, and you could see that one of the stroke survivors was talking about being 500 kilometres away from the nearest hospital, and it wasn't even a comprehensive hospital, that there is a need for us to fundamentally change the game. So rather than work with scanners that weigh about 700 kilos and having to spend all the money and infrastructure on developing ambulances that can have that kind of machinery inside, the Australian Stroke Alliance is working with partners across Australia to develop portable imaging devices, and they'll be at the centre of what we're trying to do for our aircraft and for our road ambulances out there in the regions. And a really critical part of this mission are three enabling platforms that we've developed. The first is digital technology for telestroke or telehealth enablement, because it's not as simple as just giving a flight nurse or a flight paramedic or a flight GP a portable scanner that looks like a piece of carry-on luggage. They need to be trained in it, and they need to be connected to other clinicians in that entire chain of care, from the moment the stroke onset to notification of the paramedic through the emergency services, through the transport to the relevant centre. And depending on the type of stroke that they have, they may well have very different treatment pathways and different needs with respect to that. So tele-enablement technology is really critical for us. The other is around clinical education. We have a number of different specialties that are involved in that process of care. And we're developing in Australia very bespoke training programs for our clinicians, whether they be nurses or GPs or paramedics or even neurologists that are going to engage with this model of care. So, for example, we may have someone who's in Alice Springs, which is right in the centre of Australia in the outback, who has a stroke. They may call a paramedic, for example, their family member, whoever may unfortunately find them after they've had their stroke. The ambulance will respond, and then there will be a coordinated response through our tele platform, which is called Zeus, and we'll talk a bit about that later in other meetings, that links them up to the Royal Flying Doctor Service to mobilise the stroke air ambulance to them. And then, of course, that platform will be used to notify Royal Adelaide Hospital, and will take the patient many, many hundreds of kilometres to the receiving centre where the angio team will be ready. If they've got a large vessel occlusion, we'll have the clot retrieval team ready, the INR team activated. And the clinical education underpinning all of those different specialties that are involved in stroke management is a really critical element for our mission to make sure that we are able to achieve improved outcomes. And last but not least, we have a real focus on research collaboration and evaluation. And I think that's really the core of everything for us. Everything starts with collaboration first, everything starts with research. And we're very interested in working with partners that can potentially adapt the model for their environment and then provide us the data and work with us to validate the model in different contexts as well. It's not just an Australian solution. Very much our mission is about solving the problem in Australia for now, but we know that the problem in India is very similar. In fact, I was speaking to Dr. Harsha the other day, and he mentioned statistics for stroke in India, and you have more than 1.2 million strokes in India every year, which is twice the amount of stroke survivors in total in Australia right now. So you have that every single year. So there's a huge burden of stroke in this country, and we'd really like to establish collaborations here so that we can start to understand what are your clinical service needs, the models of care that you have at the moment. We really like to start with exchange so we can bet ourselves and see how things work here, and then we get a feel for what your needs are, and you can tell us what those needs are, and we can start to develop means for collaboration and research opportunities. So thank you for watching. That's just a broad overview of what we're doing in Australia and what we hope to potentially do elsewhere. We'd love to. Thanks.
Now I kindly request Dr. George to please come on the dais.
Thank you very much, Chairman Monu, Director Raman, fellow clinicians, students. Thank you very much for having me. I've been in India for 3 or 4 days now. It's been an incredible experience. I'm falling in love with this place more and more every day. I heard a very inspiring story today about the power of one man, a man who didn't have the benefit of education, who made it on his own. And he didn't just keep that wealth to himself. He recognized that what he achieved was not something that everyone can achieve. And he created an institution which would give thousands of individuals from this region the opportunity to acquire an education and give back to their community. I'm touched. You can hear I'm emotional. The power of one man, I hope it inspires everyone to do the same and give back, and it'll make India and the rest of the world a better place. Now, about myself, I'm a clinician. I graduated from Monash University. I practiced primary care for 23 years. I called it after the event medicine, and I loved it, and I think I was pretty good at it. And then one day, I decided that I hate disease. I don't want to manage disease anymore. And roughly at the same time, 2004, the Human Genome Project sequenced human DNA. This was something that took 14 years, cost $3 billion, and it started what I call modern medicine. So from the humble beginnings of sequencing one person's DNA, we now have tests which are from cradle to grave. We have carrier testing and NIPT. We have risk stratification. We predict disease, inherited disease, which is germline, sporadic disease, which is SNPs and clinical risk scores. We manage disease. We do precision oncology. We identify the cancer. We identify the patient. We're able to create specific solutions for that person. This is called personalized medicine. We're also able to detect cancers before radiology, pathology, with liquid biopsies. We're also introducing, these are products, some of these products are specific to our company. We're introducing solutions to clinical trials to make them more accurate, to make the data more meaningful. And most importantly, we're hoping to open a biobank, a genetic biobank right here. And this biobank will create the same positive outcomes in genetics that we have enjoyed in the West, where the data has been very much biased towards the West, but now it's going to be specific to this region, which means that the quality of the data will be as good as it can be. The other beautiful thing about this technology is that there are no hurdles to adoption. I mentioned $3 billion as the cost of the first human genome that was sequenced. And today we can produce the same outcome in a number of hours at a cost of less than $800. So I'm hoping that the price will continue to come down and one day will be free. So I'm very excited, very pleased, and I'm looking forward to coming back to seeing this biobank grow, develop, and produce. Thank you very much.
Now I kindly request Mr. Nicholas to please come on the dais.
Thanks, guys. Thanks for having me today. It's a pleasure to be here with you all. As you probably heard in the introduction, I'm the only Mr. of the group. Everyone else is a doctor. So my background is in design and engineering. So for me, it's all about talking to medical professionals. Yeah. Sorry. So as you can see, as I was saying, for me, it's all about talking to the medical professionals, understanding the problems that exist, and seeing how we can use technology to assist in solving some of those issues with you. So what we have done is we've listened to your colleagues in Australia, and we've developed products that specifically meet the requirements they've raised with us. Yep. Thanks. So here at Hark Medical, what we do is we develop a virtual community of care. And what that means is it gives our stakeholders...
Hi, I'm Sasha, your friendly home sachet dispenser.
Thank you. Sorry, you can hear it has sound and lighting that matches with the product, but I'll talk you through. So what we do is we give our key stakeholders insights into their patients' medication management. And we do this in real time with a number of different options. So we have our online platform, we have our mobile apps that integrate health and wellness data in real time, and then we have our real-time devices like Sasha here, which combines a medication delivery mechanism called a DAA sachet. So these sachets here is something that's become quite popular in Australia, and what it basically does is it houses your medication into an individual packet that is coded to the user or the patient for the time, the date, and the medication that is inside. So what we do is we load the medication into the device, we code the device to the specific user through a biometric, and then we download that patient's meds chart to the device so that we know exactly when we need to be dispensing. So the problem that we were facing here is that medication adherence in Australia is quite terrible. 1 in 2 people are forgetting to take their medication, which in turn costs the government roughly $2 billion a year in increased hospitalisations and increased risk of death. So what we've designed is an adherence device that gives this additional virtual community of care or continuum of care for the medical professional to keep an eye on the adherence of the patients. With this device, this obviously is specific to our sachets, but what we're doing is designing a number of other devices, which you'll see here. This is our device called a DOSI, excuse me. And so this device here combines, so this is just an image here of our app. So obviously with our app, we also take health and wellness data in real time and we overlay that data with the dose schedule. Now this image here is sharing another device, which we call our DOSI device. This is the device here. And this device is a bit more agnostic across different medication delivery mechanisms. So it's not reliant on a sachet, which is very much a specific medication system in Australia. This is more modular here that can work with different types of medication. We have a very similar set of endpoints. So we obviously have a biometric for the specific user. We code it to the dose event through the patient's meds chart. We automatically open specific slots for that time of day. And why we do this is because we have certain conditions, so patients with dementia, we don't want to leave the choice up to them to potentially open the incorrect slot. So what we do, we know the time of day, we know the medication, and we know the patient, so we will automatically open that specific segment in the case to make sure that they're getting their correct medication. Now the beauty about this device is that that internal case is modular, and that can be any type of configuration based on 2x7, 3x7, 1x7. We've also got a modular unit that works with oral forms, so we can actually measure the exact volume that's inside, so we can chart as they're taking their medication. So this is a really exciting device, and one that we're just starting our development on, and it forms part of the system that we're working together. But that's a little bit about what we do. Hopefully we've shown you a little bit about the technology that we have. As you can probably tell, my background is more technical, so I'm focusing more on the product and what it does. But if you'd like to grab me outside of this discussion and have a chat about the other offers for the products, I'm happy to answer your questions. Thank you, guys.
Bruce. Now I kindly request Dr. Bruce Ingram, OAM, Chairman and Medical Director, to come on the dais and present us regarding the syringe usage.
Thank you, Chairman Dr. Monu, Monu, distinguished colleagues, medical students. Thank you for your very warm welcome today. My name is Dr. Bruce Ingram and I'm Chairman and Medical Director of QStat Auto-Retracting Safety Syringes. My talk is an example of the aphorism that a picture's worth 1,000 words. So with that, I'll show you a video. This is the QStat syringe. The plunger is depressed once, nothing happens. You can then put on a standard needle into a luer lock. Used later in the injection cycle. To be noted that the syringe uses to aspirate the drug that is to be injected. Once the drug has been put into the syringe, the operator has a choice of either using the same needle or of changing needles. The syringe is then put into the patient's arm. The drug is injected, the retraction mechanism comes into play, and as you can see, the rate at which the needle retracts is controlled by the operator's thumb. My interest in needle stick was first stimulated by when I was an intern at the hospital I trained at. A senior registrar got a needle stick and as a result developed encephalitis, and a viral encephalitis which subsequently caused him to become intellectually impaired and his career was ruined. So I give you this example particularly to the students to demonstrate that needle stick is real and the consequences can be devastating. Needle stick injury and its associated risk of bloodborne disease is a widespread and ever-present risk for healthcare workers around the world. There are some 20 diseases that can be contracted from needle stick, the most common of which are hepatitis B, hepatitis C and HIV/AIDS. To put that in perspective for you, if I was to receive a needle stick from a needle contaminated with hepatitis A, I'd have a 1 in 3 chance, hepatitis B, I would have a 1 in 3 chance of getting that disease. If the needle was contaminated with hepatitis C, I would have a 1 in 30 chance of getting hep C, and if it was contaminated with HIV, I'd have a 1 in 300 chance of getting that disease. These 3 diseases alone carry massive burden of morbidity and mortality, including chronic immunosuppression, chronic serious infection, cirrhosis of the liver, cancer of the liver, other malignancies, and shortened life expectancy and death. There are some 25 billion syringes used around the world per annum, of which my reading tells me about 5 billion are used in India. It is estimated that there is a prevalence of 75% of needle sticks amongst healthcare workers globally, and that this is probably underreported. We at QStat have developed a solution to needle stick with this syringe. It is single use, and it automatically configures to a safe position whereby the operator is protected from needle stick. As you noted on the video, the rate at which the needle retracts is controlled by the pressure of the operator's thumb, and the needle does not flick back at which the velocity at which the spring expands. It uses standard needles, unlike any other of the automatically retracting syringes that are available. And this is important in that it allows you to change needles between the aspiration or drawing up phase and the injection stroke, as is dictated by world's best practice. And it also means that the inventory required for your syringe needle sets is no greater than with conventional syringes. Finally, there's no added input from the operator once the injection stroke is completed, such that the device automatically transitions to the safe configuration. We here in India today, we're very excited about it. We're manufacturing in Malaysia, but we're very excited to look for partners to upscale our manufacturing and sales in India. So we look forward to collaboration in the future. Thank you.
Sir. Now I request Dr. Padma Gadia, founder and CEO of Smilo Eye, to come on the dais.
I promise I won't take more than 5 minutes. After listening to these great speakers, I don't know what I'm going to add to it, but to start with, thank you, Chairman, Mr. Abdul Rahman, Principal Sir, and everybody to come here this afternoon and listen to our Australian delegation who are part of Australian Innovation. And I'm part of that too, but I am one of you. I started just like you. I still remember my college days, where I sat and listened to speakers, achievers, leaders who had created a legacy for themselves. Today I'm moved by the story of your chairman. I always question myself. Every time I achieve another milestone, there's something more. And I thought there is something wrong with me. But looking at your chairman, no, something's not wrong with me. I'm really inspired by leaders like him. When you're a student, you are always looking for the next thing. Like, after my bachelor's degree, I'm going to go into post-graduation. What next can I do with it? After that, do I go into private practice? Do I go into public? What do I do? There is limited opportunities sometimes in our areas of specialization. How do I go abroad? Or will my degree be valid there? Do I have to give exams there? Yes, you have to. We've all given it. And if you dream, go for it. Everything is possible. We are humans. If you don't give up, everything is possible. Make failure your friend. These days we don't celebrate success in my household. If you fail, we celebrate. Because if you fail, you find 100 different ways to innovate. When I started my first practice after finishing my exams in Australia, everything was a mess. Everything. And including on the top of that, I fell pregnant. Having a new practice, understanding the Australian system, I just passed out and I started my practice. I didn't even wait to get experience from somebody else. You know, as usual, I'm super enthusiastic about everything. And then we learned. Then I went into starting another practice, helped my husband set up his medical center, cosmetic center, skin cancer center. I assisted over 400 dental practices in Australia, consulted to multiple specialty clinics. But then I realized, if I can treat, this story is not about dentistry, it's about any clinician. I was happy being a dentist. I was doing amazing amount of really great cosmetic cases as well, earning really well. But I asked myself a question. How can I treat 1 million patients a day? As a dentist who can only be on one chair, I can't. That had to be a digital solution, a technology revolution. And that's when I started Smilo.ai, where I can now make every clinician, whether you are a medical doctor, a nurse, a social worker, a physiotherapist, I can turn you into a dentist, where you can screen your patients and tell them to seek treatment. You have data-driven insights for them. We are web-based, we are app-based, and easily integrated to any system within 15 minutes. You don't require any training. Who loves selfies here? Don't tell me you're not on Instagram. Come on. I'm not considering you. You're on Instagram as well? Yeah. You can do better than that, Harsh. So are you guys on social media or not? Yes. Oh, thank you. Otherwise I would have said this bat is really abnormal. Because I am, and I must be at least, not revealing my real age, but at least 10 years older than you. Right? So in a generation where everything is swiped vertically and horizontally, I use the power of smartphone technology, powered with artificial intelligence, and we can screen patients in less than 3 minutes now. A technology that can be made accessible, affordable, and available for anyone. With a global vision, I don't anymore want to keep dentistry a privilege for the rich. Who here likes to go to the dentist, apart from the fact that we are beautiful? Who likes going to the dentist? No one. When was your last dental visit? But who likes to smile? Who likes to eat? Who likes to take selfies? And still you don't like teeth. You don't like going to the dentist. That's why we are bringing dentists to you. In your pocket. Anytime, any place. With just your smartphone. Diabetes, cardiovascular disease, stroke, pregnancy are all associated with dental issues. Oral cancer is on the rise. And yet we ignore oral health care. US doctors, nurses, physiotherapists have access to your patients. You can do intervention as well. That's the least we are asking for, and that's the collaboration and support I'm asking for, Rahman sir. Thank you. I will not take more time, but I promise to return. I've already spoken to your principal, sir, and I promise to return. Thank you.
Thank you, ma'am. Now I request Mr. Michael Kors, Director, Digitology Health Tech, to come forward.
Thank you very much for the warm welcome here. Thank you to the Honourable Chairman, Honourable Director. I've had a really great pleasure of being able to speak with your medical superintendent over lunch and also hear stories from Dr. Rohan as well, really getting to understand how deep this medical community is here at Kanachur. So thank you so much all for your time. Actually, I'm an Australian who's moved to India. I live in Delhi. And I come to Karnataka probably every 2 weeks now, but this is my first time in Mangalore itself, and I'm very excited to be back. As an Australian, we have a pretty small population. It's 2.5 crore people, which is kind of a small market and hard to work with. That's it. And Melbourne itself only has 45 lakh people in it. So what are we to do? We moved to India. But in order to be here in this country, we really need to have a strong partner, a great education partner, a great clinical partner and business partner. And we've been fortunate to form a joint venture with Medachievers, focusing on remote patient monitoring, including ambulance and pre-hospital care, where we're taking live feed of the patient in the ambulance and streaming it into the emergency room as the patient is en route, allowing them to be treated. And then also remote monitoring technology with proper made in India patient monitors, which stream into command hubs at larger hospitals. We're able to do that, provide critical care services at 250 rupees per day. And compared to a country like Australia, where I come from, per bed for critical care in a hospital costs 2 lakh per day at the government level. We're able to do the same service in India as Australia. And part of my privilege in being in this country is what we've been able to create here, we're able to take home, and all of a sudden you can have in a village or a town setting 1 and 2 bedded critical care facilities connected to the top multi-speciality hospitals on an economic basis. It is affordable for everyone if you have insurance, if you don't have insurance, if the government's paying, if the government isn't paying. And that is the depth of innovation we've been able to achieve here with a group like Medachievers. I'm so excited to be back in this campus again and to visit Mangalore far more often. Thank you all very much.
Super paramedics. You are paramedics, you create a super paramedic. We have got now bike ambulances coming in, where paramedic is going to be the doctor. With this device, when you go to the patient, you will start the treatment there only before the real ambulance comes to pick him up. So if there is a stroke patient who is dying, you will stabilize him, you conduct thrombolysis, you conduct the management program, and that is what ASA is going to do with you. They will train you, we'll give you the bike, a super bike, electrical even, with all the devices, and you will have the best future. People would take selfies with you with a device, and make sure that you look very respectable in your own community, in your family, and across the country. And that is my promise. We create super paramedics. You saw those paramedics of ASNO? Rest, stars, excitement, not like this. There has to be, I'm saving lives. Bloody, why is this? There has to be, a smile. Okay? So clap for yourself. Landscape.
Okay, ready?
Yeah.
1, 2, 3. Thank you.
Thank you, delegates. Now it's time to. I now request Dr. Rohan Monas, Chief Administrative Medical Officer, to express the words of gratitude.
Thank you so much, Pratiksha. At the outset, I would really like to congratulate the Medachievers team and our Australian delegation to making it this far to Mangalore and giving us their bit of advice and into promotive healthcare. Thank you so much. See, healthcare by and large has been constructed into various categories or dimensions, right? They talk about preventive, promotive, curative, rehabilitative, transformative, integrative. I think on this platform, we're talking about preventive, promotive, and integrative by and large. And we will get there soon. Our director, Mr. Rahman, has given the patient listening, and we're going to have discussions and chats on the same. Thank you, Priya, for being here. And on the same note, talking about dental practices like our respected dean, Dr. Colonel Kiran, had emphasized on, we have an institute called as Kanachur Institute for Craniofacial Anomalies. So what does this institute do by and large? You know, we have men and women who are young, it could be babies, it could be adults, who have malfaces, right? Who have disformed faces from birth. It could be a cleft lip, a cleft palate, or it could be like an orthognathic thing, happening, abnormal. Padma will connect even better. So what our team does is, they do a 3D design on a CT, then they also make a 3D imprint on the same. They plan the surgical cuts, and they ensure that the outcome is near normal, near perfect. This happens in one sitting, and we have the team, and our institute is recognized for the same. Thank you so much. Probably we were in talks, because our director also was in talks with some international organizations or even countries abroad, wherein we can have these people look like you and me. They have normal IQs and EQs, but the appearance, like they say, the phenotype isn't as normal. This is what we also deal with. Thank you, Dr. Harshvardhan. It's indeed a great pleasure to have you here, and we would like to host you again. And your team, thank you so much. And your entire team of Medachievers who've flown down all the way from Australia. The stroke initiative has been very inspiring. Yes, I have been a part of a stroke unit in my previous organization, and it was a JCI certified organization. So we were the first unit, for example, the first stroke unit in the world to be disease specific certified. That happened, and it was all in hospital. You guys are doing out of the hospital. So, that is the change, because weather plays a negative role by and large, mostly.
They also do certification now.
Yes.
Kanachur will have that privilege.
Yes.
To have ESA with them.
Yes. Great. No, because I have been to London Basingstoke some time back, and I had seen a similar concept where they have like a CT or an MRI on wheels. These hospitals don't afford this mega mammoth infrastructure, so they have it, wheel it, power them up, and get it done. Anyways. Going forward, we look for more exchanges, interactions with this team, and it looks very elite, looks very bright. And over lunch, like Mike mentioned, it was very candid, and Matt too. Because what also I told Mr. Marcus was that we were one of the first centers in Mangalore to even start the COVID vaccination. Well, vaccination was difficult to begin with. We had the Indian company who produced it, manufactured it, and then we got the first batch and we did it. And being an institute which was just a startup or a starter, achieving that thing, it was tough, but with teamwork we make it look easy, and it was phenomenal. All ages across, all spaces across. We went to old age homes and temples, gurudwaras, churches, mosques, and just helped all these people out, and they were so benefited by this organization. Anyways, thank you so much for being here, and namaste, and come back soon. Thank you. On the same note, I'd like to thank all the professors, our dean, our students, our faculties, and all our PG students also. Thank you for spending your time with us. Thank you. We'll close with our national anthem. Thank you.
मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you.